So now it's my pleasure to introduce Professor Bryony Dean Franklin. She's Director of the Centre for Medication Safety and Service Quality, and I think it's fair to say one of the leading experts in the world on medication safety and medication error. Though she wouldn't say that, but I will. Bryony, over to you.
Thank you, Charles, and thank you to Nick and Stephanie for a fascinating presentation, which I've really enjoyed, so thank you. Medication is the most common intervention within today's healthcare. We know that the vast majority of hospital inpatients will be prescribed some form of medication. If we think about specific groups of medication, we also know that 30 to 40% of all of our inpatients are prescribed antibiotics at any one time. Even if we move away from hospitals, of all the people who are registered with a GP, 2/3 of those patients will have at least one prescription in a given year. And of those, 12% of them are for antibiotics. So we're talking here about a healthcare intervention that affects all of us and all of our patients. We might think that medication is a fairly routine healthcare intervention, but unfortunately the figures, and therefore safe, but unfortunately the figures that we know would perhaps suggest otherwise. I've put up just some figures here about some of the literature that we have in the area showing how many patients, how many doses, how many situations are affected by error. So, for example, 5% of admissions are medication related. We know that a large proportion of inpatients suffer harm as a result of medication. If we look specifically at antibiotics, we also know about the huge burden of antibiotic resistance and of healthcare-acquired infections, such as Clostridium difficile and MRSA. So, and not only are these kind of findings there in the research literature, but they're also very much in the public domain. So this is some newspaper headlines from a year or so, about a year ago, presenting some work that I was involved with together with the UCL School of Pharmacy and the University of Nottingham. This was based on a study of prescribing and monitoring errors in general practice. So not the hospital setting, but in primary care. And it reached the headlines and the front pages of many of our newspapers. If we focus on antibiotics, this is some website headlines from earlier this year following the Chief Medical Officer's announcements about huge concerns about antimicrobial resistance, talking about an antibiotic apocalypse. And it's not just recently that these things have been raised within the public domain. Searching on the BBC website, there's lots of examples of these kind of headlines. Antibiotic resistance was also raised as a major concern in the G8 summit on the 12th of June, so just a few weeks ago. So what's the solution to all of these problems? Well, sadly, it's nowhere near as simple as solving this rather fiendish puzzle. But what I'd like to do is to give you a few examples of interventions and developments that we've developed here through the CPSSQ, through working within the Trust, with colleagues elsewhere and colleagues locally to try and identify what some of the approaches might be. I'm just going to give you a bit of a snapshot of a number of different approaches that we've looked at, and then finish with some reflections on what some of the conclusions and suggestions for the future might be. So starting with perhaps one of the more high-tech interventions, many of you will be aware of the work that's being carried out here at Imperial College Healthcare NHS Trust, led by Trust Pharmacists and working with the Centre for Infection Prevention and Management here at Imperial to develop point-of-care antimicrobial prescribing support for our healthcare professionals. So this is a shot of the Imperial Healthcare Antibiotics app, which gives us access to our empirical antibiotic guidelines, and also some really useful functions to do with therapeutic drug monitoring, calculating patients' estimated creatinine clearance, highlighting elements of our IV to oral switch policy, etc. And work has been published showing the process and the results of this kind of work. If we move from the high-tech to some of the more low-tech approaches, I'm going to tell you about the development of the doctor card. Now, you'll find out in a minute why I've got that scruffy piece of paper on the slide. But this work came out of some focus groups we did with our junior doctors, exploring some of the reasons why they felt that prescribing errors occurred within their daily practice. We talked about some of the barriers and facilitators to good prescribing. And as a course of that focus group, which was being conducted as part of another study, several of them produced bits of paper that looked probably something like that from their pocket, with like a crib list of commonly prescribed drugs, doses, routes on this scruffy little piece of paper that had often been passed down sort of generations of doctors. And they absolutely loved these pieces of paper. And, you know, when one of them got one out in the focus group, they all wanted a copy of it and copying ideas of, oh, I didn't have that drug on mine, and can I do a swap if I copy these details down? So it occurred to us that actually we could do something that provided the same function but looked a little bit nicer than that, and ideally was in line with trust policies, with local formularies, with drugs that are still currently recommended, and was hopefully something more usable. So we worked with some of our junior doctors to develop what we've called the doctor card, which stands for the dose reference card. It's a credit card sized card that can fit into your ID card holder or into your pocket. You do probably need to be under the age of about 45 to read some of the text on it, but our junior doctors didn't seem to have a problem with that. On one side, we've got some of our most commonly used drugs and doses, all in line with our local trust prescribing policies. On the back, we've got insulin sliding scale and the warfarin initiation protocol. On the version that we've produced this year, we've also got the QR code to link to the antibiotic smartphone app. So if people want the antibiotics information, they can download that directly from the card. And we gave this out to all of our junior doctors who started last summer, and we did a follow-up evaluation where we asked them, had they received it, which is the first question, and they all had. Were they still using it? And this was 3 months after we'd given it out, so 70% of them were still using it. And we asked them which parts of the card they'd found most helpful, and generally it was the dosing guidelines for the generally used drugs. We asked them, did they think we should repeat it for this year's cohort starting in August, and the vast majority all said yes, so nearly 90% said yes. So we've now updated the card this year. We're just in the middle of having it reprinted, a few minor tweaks to the format with a hole in it so they can thread it onto a lanyard if that makes it easier, and we're going to be giving that out this year. So a relatively low-cost intervention that hopefully just provides that information at the point of prescribing. One of the things the doctors talked about in that focus group was how they did feel often quite thrown in at the deep end when they first qualified, and they didn't like to be seen to be having to ask somebody for commonly used drugs and what their doses were. So hopefully this gives them that information in a sort of relatively easy to use format for those first couple of months. So those two interventions are both based on ways of providing information at the point of need. Other work building on the work that Nick and Stephanie have talked about teamwork. We've also been looking at dynamics and use of pharmacists and other medication-related tools on multidisciplinary ward rounds. So this is just an example of some of the work that we've done, led by my colleague Gavin Miller, who did some work comparing pharmacists attending multidisciplinary ward rounds with pharmacists doing their own thing, going around doing their own separate ward pharmacy service, and found a massive increase in the number of interventions and contributions that they made. So instead of making one contribution to patient care an hour, they made one, I think it was every 8 minutes. So a huge difference by being part of the team, by having a shared understanding of what the treatment goals and priorities were from that patient, and from being available at the point of need, which also very much builds on the recommendations in the Francis report about multidisciplinary ward rounds. Still on the topic of ward rounds, this is some work that we did a year or so back within the paediatric department at St Mary's. So this built on work developed by Gordon Caldwell, a consultant diabetologist from Worthing Hospital, who developed a checklist type tool for use during a consultant-led ward round. It's sort of a combination of a checklist and a kind of real-time audit. So there's a list of things to check on a given patient's drug round. So very straightforward things: is the allergy status completed? Are all the medication orders signed and dated? Are they all legible? Are they all generic rather than brand names? And you can adapt it to a different set of things. So you might introduce things to do with antibiotic durations or whatever it might be. So we use this within the paediatric department here at St Mary's for about a 6-month trial period. And this data shows the technical error rate, which is things to do with not the clinical choice of drugs, but is it clear, is it signed and dated, has the patient got their allergy status. And we did this using an interrupted time series analysis, and you can see that following the introduction of check and correct, we had a significant improvement in the technical error rate, which was then reduced. So it's partly because having to complete this checklist makes the team pick up the drug chart and look at it, and it's partly because when you then identify any problems, they get rectified, and it sort of highlights the importance of that, of good quality prescribing amongst the team. And we're going to be doing some more work with this with a PhD student who, a bit like the work that Stephanie and Nick have described, we want to look at how using things like this on a ward round changes the types of discussion, changes the dynamics, what the barriers and facilitators are to its use, and how we can make better use of such tools. And this work was published last year. This is a study we're currently in the middle of doing, looking again at supporting prescribing by our more junior prescribers. So this is funded by the Health Foundation's SHINE programme, and what we're doing is trying to make better use of the current situation in which doctors will make prescribing errors. Pharmacists see every drug chart most days and will identify prescribing errors. In many cases, they'll correct them themselves if it's very obvious what was intended, and particularly if the doctor's not on the ward. It's often quite easy and much quicker just to correct it in green pen on the drug chart. In other cases, pharmacists can't identify the prescriber concerned, and they'll ask another doctor on the ward perhaps to change the prescription. Or indeed, if you can identify the prescriber, they may have gone home, they'll be off shift, or you've got somebody else standing next to you on the ward. But this means we're not completing a kind of feedback loop. So our junior doctors don't get to find out about errors that they've made, which loses the opportunity for learning from them. You can't reflect on your practice unless you know a little about how you're doing. So we started off by doing a range of different approaches, and one of them was to do some focus groups with some of our junior doctors, and these are some of the comments that they came up with. Notably, there was a real disconnect between the pharmacists' views that they spent a lot of their time identifying prescribing errors and correcting them, versus the junior doctors' quotes, and there were quotes and comments along the lines of, well, I've never made an error. I've never been told I've made an error. Oh, I do get asked to change drug charts quite a lot, but that's not an error. Oh, I suppose it must be. And we got a sense that the pharmacists, perhaps because they want to support constructive relationships with the doctors on their wards, I think they're all being terribly nice and terribly British about it, and asking if they could possibly maybe just change this prescription from 100 milligrams to 1 milligram or whatever it might be. But we're not actually having the conversation that points out that this was an error, and why do we think it might have occurred? Is there something that needs changing in our policy? Is there something that the individual might need to reflect on to think about why that occurred? So what we're doing now is working with both our junior doctors and our pharmacists to create good phrases to use that highlight that they've made an error without it being completely, obnoxious, something that both sides are comfortable with, so that hopefully we can complete that feedback loop. We're also doing some work. We're going to be developing sort of error of the fortnight emails which highlight common or particularly potentially dangerous errors that go out to our cohort of doctors, and we're doing some measurements on prescribing error rates by junior doctors to hopefully show that this will be something that makes a difference. So again, very low cost because it's based on a system that we have already, but by trying to make the feedback a little more explicit, we're hoping to make that much more useful. So what next? Those are a couple of projects that we've got that we've either just finished or have got in progress at the moment. I also wanted to highlight a few that we're going to be doing over the next year. We've been doing some work with one of my PhD students, Zamzam Ahmed, who's doing her PhD at UCL School of Pharmacy to scope out the use of electronic prescribing in hospitals. Now, I think lots of people feel that electronic prescribing will be a huge benefit in terms of patient safety. We've done a national survey where we contacted all 165 acute trusts in England and looked to see how many of those were currently using electronic prescribing to try and scope out the current state of affairs. We had 101 who replied, and of those, 70% are using some form of electronic prescribing at the moment. However, of those 70 hospitals using some form of electronic prescribing, 13 have what we called pretty much across the board inpatient electronic prescribing used in most or all clinical areas. The other 57 have got perhaps a system on 1 or 2 clinical areas, or they're just using it for discharge prescribing, and there's a much more piecemeal approach. But interestingly, and what's not previously been looked at documented in the literature, is the huge prevalence of hospitals who had more than one electronic prescribing system running in parallel. So of the hospitals who have electronic prescribing, more than half have more than one system. So, and I think several hospitals had 4 or 5 systems running in parallel, perhaps on different clinical areas, or one system for inpatients and one system for discharge. So the patient safety consequences of those, with prescribers, nurses, other healthcare professionals having to use different systems with different levels of decision support, different training requirements, is something that we want to be looking into. Locally, those working in the Trust will know that at some point in the not too distant future, we're going to be introducing Cerner electronic prescribing and medication administration systems. So we've also been piloting methods of collecting data that we'll be able to use, hopefully, to study the impact of that. We're going to be doing a time series analysis where we're collecting a small amount of data each week or each fortnight, so that we'll be able to look at any settling in effect of the new system on a number of outcome measures. And here I've got some on prescribing error rates and patients for whom their doses were not observed being given and were just left at the bedside. We've got a whole host of these measures. We're also looking at things like the effect on the teams and nursing practice. So what we call the spaghetti diagram here on the right is showing where a nurse has to walk doing a drug round for just 8 patients. And that's the amount of walking that the nurse has to do. So we'll be able to pick up whether there's significant effects on those sorts of outcome measures when we change to an electronic system as well. On the topic of electronic prescribing, we're also going to be doing a study. The acronym is IMPRESS because it was a cool acronym. It stands for Inpatient Medication, Patient Relationships and Electronic Systems, which is a bit of a mouthful, so you now see why we've got an acronym. With this, we're interested in how hospital inpatients are involved with medication safety behaviours, both what patients currently do, but also what they would like to do. And in particular, we're interested in how this might change when we move from paper-based systems to electronic-based systems. So instead of having a piece of paper at the end of patients' beds that a healthcare professional can talk through with a patient's medication records are going to be on a computer that you need a login and a password to access. So we'll be studying both a hospital using paper-based and one using an electronic system to see how these things might differ, and then working with groups of patients to identify what sort of interventions might be helpful, would they like to see, that we can then develop and roll out and test in a future study. And this study was also developed partly because of some of our own interests, but also through conversations with patients. And in fact, it was one of our members of the public who is a co-applicant on this study who came with us to the interview to the funders and was very much involved with driving this forwards, which I think is a really positive step in terms of something that's got real significance to our patients. The Centre for Infection Prevention and Management are doing further work to develop the smartphone applications. So as well as the hospital-based one, which I presented earlier, there's work currently going on to develop a point-of-care antimicrobial prescribing support for GPs and for prescribers in primary care. Also looking to see whether there's scope for developing an equivalent tool for our patients to use to provide antimicrobial therapy information. So we're really looking at linking the whole health system and not just looking at hospitals in isolation. CIPM are also looking at how we can make better use of our entire workforce within the issues of safe use of antibiotics. And this is a paper from the centre highlighting how a lot of these interventions and papers and thought pieces completely ignore the role of nurses, a really, really important omission perhaps in how we're looking at antimicrobial use within our hospitals. And the team are going to be doing some work to look at how we can take this forwards. So I've highlighted a few examples. As I say, the solution is much more complex and probably not even as easy as that thing. But I've got a couple of perhaps reflections on where we might want to be looking. Within the centre, we're very much of the view that safe antibiotic use is very much part of patient safety rather than being a completely separate area, which is perhaps how it has been seen in the past. Notably, a bit as Stephanie has said, all of these developments have come from joint work between researchers and healthcare professionals, but the majority of them have also had input from our patients and the public in terms of how we can develop and design interventions that have got real meaning both to healthcare professionals and to patients. A couple of other things that we feel are important. We need to do, our work needs to understand the behaviour of all of these players within the system, which is where the expertise from the psychologists and the patient safety researchers is so important. We need to understand the interactions between all these players in our pursuit of safer healthcare. We need to make use of the information that we're increasingly going to be able to have as part of the technologies that we're all moving forwards. And probably a completely different presentation, which I haven't got time to go into today, but also wanted to flag up that we also need to understand any unintended consequences of the interventions that we make and how we can mitigate those. So I'm going to finish there, and we'll be very happy to take any questions. Thank you.
Transfusion practitioner for Imperial. Your app idea has triggered one for transfusion as well, and we've now brought one out nationally on platelet prescribing because we felt it was often inappropriately done. And appropriate use drives blood transfusion in the United Kingdom, and now we're looking to do it for all of them. But it's interesting, there was an Imperial doctor who had used the platelet app here that was talking to my colleague and I that said, can we have the same sort of thing? And I think smartphones, I look at mine constantly, so I think we will see a rush of them. I mean, certainly platelets we're starting with, and we are looking to do it nationally for all blood components now. So I think it is the way to go, because it's instant information. The only issue we found is that patients complain doctors were looking at their phones and not looking at them.
Absolutely,
so we have
yeah.
to encourage them to sort of discreetly look perhaps and then go and prescribe rather than sit there doing this.
Absolutely.
They don't get that that's why they're looking at their phone.
No, absolutely, and that's one of the streams of work that the researchers within CIPM are looking at, because there is that potential concern. And often I think the concern comes from the work that has been done within our group. Often it feels the concern is more from the doctors than from the patients, that they're concerned that the patients will think they're checking their Facebook or whatever they're doing rather than looking at the prescribing policy. So maybe one approach is to be open about it and say, oh, I'm just going to check what the policy is on that, I've got it on my phone. But absolutely, and it's interesting how these things are going to change those interactions, isn't it? Thank you.
Other questions, observations, reflections, stories of medication disaster?
Don't want any of those.
I just have just a question. The junior doctors that weren't using that really helpful card you developed for them, did you find out why they weren't using it? Because there was anything between 20 and 50% across some of those.
I mean, the majority of them were still using it and carrying it. Those that weren't, there was a few that had lost it. There was a few that didn't get it because they weren't in the education sessions where we gave it out. And although we had the list of non-attenders and sent it to them in the internal mail, there was a small number that got missed. But the others, generally, it's because they'd lost it, is what they put on the feedback form. We didn't have any that said, because I thought it was rubbish, but perhaps they wouldn't have put that on there either. So you've got to take that with some, interpretation.
Bryony, do these interventions have any impact on what you put up at the start in terms of the actual rate of prescribing errors that were being made by junior doctors?
That's probably another presentation in itself as well. I mean, I'm sure as you and many people will know, because it is very difficult to measure impact on, say, prescribing rates or harm. If you look at harm, fortunately, it is rare enough that you have to have a massive multi-centre, several years study to start picking up those sorts of effects. If we look at prescribing errors, to have a robust enough way of measuring it does require quite laborious manual data collection. We can't rely on incident report data. We know that only about 1 in 100 prescribing errors ends up as an incident report. So in some cases, like the check and correct study, we can show a reduction in error rates because we were measuring that. Things like the doctor card intervention, we didn't have any enough funding, enough resource to measure the impact on error rates. The study we're doing at the moment with the feedback to junior doctors, we are attempting to measure error rates, and hopefully we'll be able to see that effect. So it sort of depends on the study and the resource available.
Maybe we'll take one more, Neil.
Charles, thank you, Professor Fack. Super presentation. I was wondering whether you are using or see any potential for using the feedback from patients. Because one of the things, I run an organisation obsessed with patient feedback, especially with advances like the friends and family test. We're seeing large volumes of patient feedback where they're commenting about their drugs, commenting that they were given the wrong drugs. Because, of course, the person in the healthcare team who's well positioned to say it's the wrong drug is often the patient. How do we harness that sort of feedback from patients as part of the safety and the monitoring?
Absolutely. Well, that's the sort of thing we're hoping to pick up on in the IMPRESS study, so the one where we're looking at inpatient roles with that. The other thing that's potentially relevant to that is we've got a focus group in 2 weeks' time with some members of the public and patients about their perceptions of errors and feedback and this sorts of things. So it's very much the kind of area that we do want to build on, but in a way that we can use that usefully in terms of feeding into what we do. So yeah, very good point. Thank you.
One more, Bob. Yeah.
That was wonderful. I wonder whether you think the solution to these multiple systems will be interoperability and weaving the systems together, or scrapping the multiple systems and ultimately having one system?
I think that's probably something that we'll need to look at and reflect on some more. I suspect it's going to be the former, because so many places have got systems that have developed, perhaps bespoke ITU systems, bespoke oncology systems that do what they do very, very well, and probably better than a generic system. But that's a really important question. Is having one system good, or is having multiple systems that do what they do good? But either way, there's patient safety consequences that I think we need to understand and work how to mitigate those. That's a long-winded way of saying I don't know.
Thank you, Bryony.